So today we have Dr. Martin Chasen presenting. Dr. Martin Chasen is currently Medical Director of Palliative Care at the Ottawa Hospital Cancer Centre and the Medical Director of the Palliative Rehabilitation Program at the Elisabeth Bruyere Hospital in Ottawa. Born in Victoria, South Africa, he completed his undergraduate training in medicine and surgery at the University of Victoria in South Africa. He later went on to obtain a specialist degree in internal medicine and medical oncology, as well as a Master of Philosophy in Palliative Medicine at the University of Cape Town, South Africa. I want to jump to talking about the Palliative Rehabilitation Program, since Dr. Chasen will be talking about that in detail today. So the Palliative Rehabilitation Program is a new concept that attends to the needs of patients with cancer and their families. This program provides patients with a rehabilitative, individually tailored program of exercise and activities, nutritional advice, psychological help, and social services assistance. Dr. Chasen has initiated a number of research programs in this area. And as a medical oncologist, he treats patients with head and neck cancer and participates as local principal investigator on a number of studies. In the interest of time, Dr. Chasen, I'm going to pass the proverbial mic over to you and let you begin.
Okay. All right. So I'll just start. Thank you very much for that introduction. Just to say, at the moment I'm in Ottawa, but hopefully by the end of June, beginning of July, I will be moving to the Greater Toronto area, and I've taken up a position at the William Osler Health Centre, the Health Service. I'll be working as leading up the palliative care program and as a medical oncologist there. So I'll be closer to where you guys are, and I'm hoping that we can continue this relationship. So the palliative rehabilitation, I have presented to this group before, so we've got so many new results coming out, so I'm going to present more on the results than on the actual concept, which was all put together for me just a day or two ago because of the results that are just starting to come out. So let's just, how do I move this forward now? Oh, I'm not moving forward. Oh, there, sorry. Okay, so just to give you a bit of the history of cancer rehabilitation, in 1971, and it's a long time ago, that National Cancer Act came out when they said, how are we going to beat cancer? Well, what we're going to do is we're going to put as much money as we can into it, and we're going to develop the best drugs and get the best surgeons and oncologists. But at the same time, they said in 1972 that the National Cancer Rehabilitation Planning Conference actually took place, which was sponsored by NCI. And during that time, they said that along with a great anti-cancer chemotherapy, one needs to optimize the level of physical functioning of patients and provide the correct psychosocial support and provide the right vocational counseling. Remembering, of course, that vocation is not just necessarily work, but to be a parent is a vocation, and to act as a child is a vocation. So, and at the same time, they said optimizing the level of social functioning. This would be very important. So, if a person, for instance, has a colostomy or has an esophagectomy, for them to go out and eat a meal at a restaurant is very, very difficult. So, one needs to optimize and maintain a person within their social environment. And so, kind of what they said is that I don't know why this is jumping like this, sorry. That the interdisciplinary team's objective is using an interdisciplinary approach to try and empower patients who are experiencing this loss of function, of fatigue, malnutrition, or psychological distress, and as a result of the cancer or its treatment, to try and improve their own quality of life, so that a patient doesn't feel helpless, hopeless, or abandoned. We don't want them to do it. So who can be part of the team? Well, nurses, doctors, dietitians, social workers, spiritual advisors, volunteers, anybody that can bring something to the table that can help a patient within his environment and that can contribute. There's no real overlapping, standing on other people's toes. You put the patient and the family at the center of attraction, and then you win. Now, what is important here is that we see that many cancers, even before they really diagnose, patients present with weight loss. And so what is important about weight loss is that, you know, if you can have 5 to 10% of weight loss, or you can have greater than 10%, and majority of those cancers that are advanced actually present with more than 10% of weight loss. Look at this, 38%, 30%, 26%. And why this is important is that there's an indirect correlation between patients with weight loss and quality of life, saying that the more you lose weight, the worse your quality of life. And that's important to remember. At the same time, we speak about exercise being a major determinant of patients' functional capacity. And we already know now that exercise is not just a suggestion, it should be a prescription. Patients' mortality. You have cancer and you start exercising, you decrease your risk of recurrence. If you don't have cancer and you exercise, you decrease your risk of developing cancer. Over and above the rationale and just for feeling better. So we see, I mean, this was a study that was done and published on patients with advanced brain tumors, and we see there that it's maybe not just the patient's endurance, but actually the exercise behavior, measured in this metabolic equivalent tasks per week. Seeing that those patients in this particular study, and it's in breast cancer and it's across the board, the more metabolic equivalent tasks, hours of exercise you can do per week, the better your survival. This is a cutoff point at 9. So, and many other randomized trials have shown that the cardiorespiratory fitness, your quality of life, and fatigue, the best medication, the best intervention that we have against fatigue, which is prominent, most important symptom that we're treating, is exercise. So, and that's for patients during and after their primary therapy. And I know what's going on. You see a lot there. And so other members of the team, we've spoken about the, the dietitian and the physiotherapist and the nurse. What does the nurse do? The nurse is a very important part of this team because she triages and screens the patient to see whether they will, in fact, be eligible for our program. We get many patients that come to us and that have been referred as, instead of going to palliative care, go to rehabilitation. So that's kind of why we called ourselves palliative rehabilitation. So our nurses will see, what does the patient feel this disease? How is it affecting them? How is it affecting their family? What support services are there? Our particular nurse has an interest in sleep hygiene. So she specifically looks at our patients because we know that 50% of our patients don't sleep. And those patients that don't sleep have a lot more symptoms. So whether it's the symptoms or whether it's the lack of sleep that contribute to the poor quality of life, we're not sure. But sleep is a problem. And the evaluation of symptoms, the nurse is very, very involved in that. What about social support? Because I think that we're beginning to see more and more and more how important actual social support is from a very young age, as far as possibly even inflammation. Patients that don't have a very good childhood or a traumatic childhood do suffer in later life because of that, even from physical illnesses. So a study that was done just recently in Journal of Clinical Oncology, remember, this is the Bible Journal of Medical and Radiation Oncology, is the Journal of Clinical Oncology, publishing an article saying marital status and survival in patients with cancer. So what did they find out? They saw that patients that were unmarried had a significantly greater risk of presenting with advanced disease. They were the patients that didn't get proper treatment, and they were more likely to die as a result of their cancer. And even after adjusting for all the demographics, the treatment, the stage, marriage remained associated with a relative reduction in cancer deaths, ranging from 12 to 33%. Now, this is an important figure, because if you consider that if you look at all the hazard ratios for overall survival of benefit of chemo with the observed hazard ratios for survival associated with marriage, the survival benefit of marriage was larger than the published survival benefit for chemo for more than 5 different types of cancers that were studied. So it really makes you think the importance of social support, not just thinking that we're going to stop the patient's nausea, we're going to stop the patient's pain, but how are we going to actually get this patient as part of into a support system. And so this is our team that we have at the Elisabeth Bruyere. We've got OTs and physios and nurses and doctors and dietitians and research people, and of course we've got the clinic supervisor, who is very important in that she helps the patients reduce their anxiety whilst they're in the clinic, making sure their appointments are on time and navigating them through the system. Many of you may recognize Professor Neil MacDonald over here, and he's been a long-time mentor and part of the program. He started the first program of rehabilitation at the Jewish General in Montreal. So our way we work sorry. Then this is our goal. It's the palliative rehabilitation is to enhance the physical, psychological, social, and professional well-being of the patient, taking into consideration the limitations imposed by the disease or treatment. So we try to help people in all spheres to put back that which they've lost. We know that cancer is really associated with loss. One can lose your breast, you can lose your work, you can lose your job, you can lose your hair, you just lose. And what we try and do is we try and replace that. And the way it's done is that the patient and their family caregiver come in, and we all see the patient for half an hour. They'll see the OT, the physio, the dietitian, the nurse, the doctor, the social worker, and then afterwards we sit together and we work out an individualized program for the patient. So the basis of the program really is physiotherapy, and then adding in either the OT, the nurse, the social worker, etc. Patients fill out quite a number of questionnaires like the ESAS or the PGSGA, the distress thermometer, the coping thermometer, the HADS. We send it to the patient before they actually arrive at the clinic, so they've got it at home, they complete that in their own time, and then they get to see us. And after 8 weeks, we repeat that whole performance, and some of the results is what I'm going to show you today. So these are the assessments, the symptoms, the functionality, the nutrition, psychosocial well-being, spiritual well-being, and we actually also do some caregivers assessments, and at the end of the program, we have patients give their satisfaction survey. So these are the criteria for admission. Patients should be adults, have a relatively good performance status so that at least they can get to the clinic. If they're unable to be ambulatory, they can't come to the clinic, then they're not eligible. And needing assistance in at least 2 areas. So patients with malnutrition, not able to eat properly and tired, would be the kind of patients we would see. Also a lot of pain, or patients having psychosocial issues with malnutrition. As I said, we see the patient, we work out an 8-week program, and we do a completion assessment at the end. And so from here on, I'm going to give you some of the results. Some of these have not been shown before, some of them have, but these are basically the updated, and I think they're very exciting, and so I think the comments is what we need to speak about afterwards. So we've had 308 patients that have referred, and 163 that have completed the program. So a lot of these, in the initial first year or two, we were marketing the program. So a doctor would send us the patient. We wouldn't just say he's ineligible. We would take him in until we could really get the oil circulating within the machine so that it could start moving, and we would get referrals. So now we don't take patients with stage 1 and 2. We take with advanced disease. And as you can see, we've had almost 50-50 of the male-female ratio. And a wide variety of cancers, that's as they come. We didn't specifically go out and try and recruit any particular type. But head and neck, of course, we've seen because those are the patients that I treat. So, and they do really well in the program. And breast being a very common malignancy, we do see quite a lot of breast cancer, patients with breast cancer, colorectal, lung cancers, etc. And looking at the ESAS, and these are time 1 and time 2, so that's before they start the program and 8 weeks later. And just kind of having a look through the pain, we don't do too well on pain. Pain remains a big problem, but certainly the fatigue and the anxiety. And anxiety you're going to see is very important, the effect that this program has on the anxiety, the appetite, and the well-being. Now, well-being is a very important ESAS determinant because well-being you can actually correlate and predict who's going to come to the emergency room just by looking at well-being of the patient. So those are important. And looking at the effect sizes as well as the p-values, this is statistically significant. This makes a difference to the patient's life. If his well-being is better, if his anxiety is better. This is the patient-generated subjective global assessment. This is a nutritional screen. Once again, done at the beginning of the program. We know in all patients having a value of 7 or 8 or above should be seen by a dietitian. So as the nutritional screen went to time 1 to time 2, we saw a statistically significant decrease, meaning that the patient was less malnourished, had better eating skills, less pain, less nausea, less vomiting, and less all the symptoms that are associated. All right, so this is the MDASI. When we say to the patients, please complete looking at how the disease or treatment has affected your general activity, your mood, your work, your relationships with others, your walking, and your enjoyment of life. And across the board, this is a very good instrument to use for patients. And we can see that the program from time 1 to time 2 has a statistically significant impact on what's going on in these patients' lives. So, next slide, please. And that, look at the multidimensional fatigue inventory. We still need to work on fatigue. This is, as I say, our most common symptom. And so for the general fatigue, we've made a difference. But the physical, the decreased activity, decreased motivation, and the mental fatigue actually seems to get worse. Not statistically yet, but fatigue is a problem. And the way maybe it's the way we are assessing it, but as you know, there's many assessment methods, but the MFI is ours. Next slide, please. The physical measures, you know, very many people say, well, you're showing me all paper. What about the physical measures? Well, the Berg balance, which is a measure of balance of the patient. You know, patients that aren't so balanced can fall, with the proprioception problems that they have, can't walk down the stairs because of the peripheral induced, the chemotherapy induced peripheral neuropathy. The reach forward is improved. We've never found grip strength to be significant and helpful for us. We've used it because it's a significant and helpful tool for patients that are the frail elderly. But the timed up and go, which is so important functionally, we ask the patient to stand up, walk to the door, and walk back, all showing a statistically significant improvement. Next slide, please. Here's the gold standard, the 6-minute walk test. So I've seen that our patients have, I think 45 meters is what is regarded as statistically significant. Our patients went from about 350 meters to 417 meters. So statistically significant improvement in their 6-minute walk test as well at the end of the program. Okay, next please. So what do we see? We see that these improvements in the fatigue domains, we see nutritional status has improved, the symptoms are interference on the mood, enjoyment, general activity, walking and work, and several other symptoms, and endurance and balance, and even ECOG function has improved. Please go, next slide. And none of the patients actually, and this is important, have experienced any worsening. Now, why is this important? I'll tell you why. Because if you look at the work done by Lisa Bruyere on ESASs in patients with advanced cancer in Ontario, that say there were 10,000 ESASs from 6 months before they died until they died, all the ESASs really kind of stayed the same until 6 weeks before they died. And what we've seen is we can actually change the ESAS. They don't remain stable. They're actually improving. So I think that's important, that we can offer something to people and say, well, you know, you're going to improve as far as your, as far as your tiredness is going to improve. You're going to improve in your appetite, your well-being. This program does help to improve that. Next slide, please. Okay, so some of the next results I thought, which nobody has seen before, and I'm really going to start advocating that the distress thermometer, which is a Canadian tool, which is so excellent and developed by Mark Fitch and Doris Hell, and we don't see many people using it across Canada, but it's something that's really good. So the distress thermometer with the Canadian symptom checklist, all our patients fill this in, complete it before they start and after the program, and I'm going to show you a little bit of later data as well. Next slide, please. So just really looking to see, these are of the 163 patients at the time that they saw that they filled it in for the first time until the time they filled it in at the second time. Just having a look at, you can see 28 patients had housing complaints at the beginning, 14 at the end. The important ones to look at is depression, 72 versus 60, nervousness and anxiety, 55, adjusting to illness, and 91. As I said, you know, that boredom, look at boredom, 68 patients out of 163 were bored. These are patients with advanced cancer that have probably been told, well, you know, go home, there's nothing more we can do for you. They were bored, they didn't know what was going on. And at the end, only 40 of them completed it. Adjusting to changes in appearance. Do our patients, you guys know, you know, take a patient with head and neck cancer that weighed 200 pounds and make him 140 and take away his voice and he can't eat properly. He doesn't look the way he did, or a young pretty woman that doesn't have hair anymore. Change to appearance is important. And look at the faith. Relating to God doesn't seem to be a big change, but look at loss of faith. I saw that just yesterday. I only got these results yesterday, so I haven't looked at them properly. But loss of faith, 11 patients said that was important in causing them distress, and at the end, only 3. Faith in mortality, 45 and 34. And information, just look, lack of information about maintaining fitness. At the beginning, 65 patients said that was an important thing causing them distress, and at the end, only 13. They were still having a problem. So it's not, they're not all gone, but you know, we're certainly alleviating some of that. Next slide, please. Next slide. Okay, so those, and the physical complaints, once again, look, this gets worse. The pain gets worse. Well, the patients have got more advanced disease. So it seems to be getting worse. Fatigue, 115 goes down to 97. 47 for breathing, dyspnea is a big problem. Constipation, 51 patients, 63 with the tingling, 58 or 41 with the sexual problems, and cognitive problems. You know, 65 out of 163 patients said they're forgetful. Some of them are feeling confused. They all seem to be decreasing except for the pain. We don't do well with pain. Pain is a problem with patients with advanced cancer. Next slide, please. So these are the top 10. I always used to say it was PD and F, pain, depression, and fatigue. But if you have a look at the time one, we've got fatigue, anxiety, and pain. And it's changed. The pain and anxiety changes towards the end of the program. So number 2 is pain, number 3 is anxiety. But look at number 7, the boredom. Boredom disappears from the top 10 with the after the program, which is quite good. And the lack of information about maintaining fitness also disappears. So we seem to be doing something for boredom and lack of information about fitness. Next slide, please. And just having a look to see at the influence really of what the housing does, how much does the program affect the housing, the transportation, emotional problems, adjusting to illnesses, load and boredom. You know, the program, look at that p-value for boredom. We've certainly made a difference in boredom. There's no p-value, it's not been reached yet, for the boredom. Loss of faith, 0.029, facing mortality, sense of purpose, information. This program works, guys. You put effort into it. It's not a tablet. It's human healing that takes place. Next slide. You're looking at the physical problems. Pain, as I said, nausea and vomiting, those are something that we need to work harder. Swallowing, lack of appetite, swollen arms. Next slide. So the program had a significant effect on the following distress items: the housing, financial, school transportation. Well, our patients do all see social workers, so that's probably the reason that we alleviate a lot of that. Emotional problems like anxiety, adjusting to illness, and religious concern, loss of faith, sense of purpose. Well, we always say to our patients, there's 3 things that only they can do, we can't do for them, and that's to try and walk for a half an hour a day, and to try and eat properly, and to try and wake up in the morning and say, I'm glad I'm alive today because ... and try and fill in what's important. Now, across the board, in patients with an ICUs from cardiac disease, those that have some type of a faith or some have a purpose seem to live longer. Informational needs continues to be a big problem for patients. They really want, even in today's world of technology, patients still don't know where to find it, how to look properly, who to discuss it with, and then the physical problems due to the cancer or due to the treatment. If they're too weak, they can't have proper ADLs of bathing and dressing, and mouth sores, swallowing, tingling hands, sexual problems, which we haven't even started to address, but they're there, and the more you ask, the more you'll find. Next slide, please. And these are the distress levels at the time of 1 and time 2 of the program. You can see in the statistically significant improvement and the effect size of 0.4. So this has really made a big difference to patients in the distress level. Next slide, please. And so looking at the frequency of complaints grouped by the categories of diseases according to the Canadian Symptom Check level, practical problems, we had 141 patients, the sum of the practical problems going down to 87, emotional problems 419 going down to 316, spiritual, religious concerns, these are informational concerns from 167 going down to 71, and physical problems going down, statistically. This is important. I mean, patients have physical problems, they have cognitive problems. Next slide, please. And that's just in a bar graph, showing the physical problems, how that improves, the emotional problems improve, the practical problems improve, and the informational concerns improve. So a good measure, a good tool, a validated tool. I'm just not sure why more people aren't using it. Next slide, please. Okay, and now this is kind of the acid test. These are patients with advanced cancer. These are patients that are not receiving anti-cancer therapy. These are patients that have been told, go home, there's nothing more that we can do for you. And they've come and they've had an 8-week program. And then we do a 3-month follow-up and we do a 6-month follow-up. And I'm only going to really present the 6-month follow-up, and that we've just got 26 patients because it's a relatively new program. Well, certainly this information, because patients sign informed consent when they come into the program, and in the past while we've added in that they will do 3- and 6-month follow-up. It's not a physical examination, it's just we send questionnaires to their house, and they complete the questionnaires, and then they send them back to us. So once we've had more female patients that have gone through the 6 months than the male patients, just a wide variety of diseases that have answered the questions and that have sent it back. Next slide, please. And here's the ESAS. And just have a look, guys. Just have a look at anxiety. Anxiety is that light blue line, and really seeing that there's a big improvement. At baseline, this was statistically higher than completion, and at the 3-month follow-up for the anxiety. And at the 6 months, it's still relatively low, better than it was initially when we had seen them. And the well-being, which I told you was such an important evaluation. Somehow the program has initiated a feeling of well-being that seems to be maintained. It's only 25 patients, but it seems to be maintained. Tiredness, you can see, goes down to 3 months, and at 6 months starts coming up again. So it's a little bit of nausea that the patients have got. The depression does go down for the first 3 months, and then at 6 months seems to be elevating again. No obvious statistics. This is just still very small sample size. Next slide, please. And the fatigue inventory getting worse, which is what we thought. Patients with advanced cancer, they do get more tired as the time goes on. So at follow-up, at 3 months and at 6 months, patients are getting more tired. Their physical, their general, their mental fatigue seems to probably be about saying the same. Their motivation, still very small, but there are trends here. Next slide, please. Malnutrition. These are patients that were told, we're not eating properly. And remember that quality of life is associated with weight loss and malnutrition. We're still going down. That PGSJ is improving until 3 months. At 6 months seems to have started to get worse. Patients with advanced cancer. Next slide, please. And this is the MDASI, symptoms interference with your general, your mood, your work, your relationships, walking and enjoyment. No real statistics yet, just seeing that work seems to be getting worse. The higher the score, the worse it is. Relationships, enjoyment of life got better, then starts to get worse. I think too early to really see what this means, but we do see patterns here, going better until 3 months, and then it's starting at 6 months getting worse. Next slide, please. And the distress thermometer gets better until 3 months, and then seems to be getting worse until 6 months. So once again, following that pattern, better at 3 and getting worse at 6. Next slide, please. And the HADS, but the anxiety continuing to decrease. So that seems to be a pattern. This program seems to have effect on anxiety. And even if these are not statistically significant, what we're saying is we can change the ESAS. Even if the patient's only going to live 6 months or 7 months, If that 6 months is going to be full of quality, isn't that our aim? We're not, maybe not improving survival, we don't know that, but we're improving quality of survival. And I think that's what, certainly in this group, is what we're all about. Next slide, please. And this is important because I think this gives us, for the first time, we've got an article that just came out now. This gives us a tool that we can probably, and will give us an intervention. How do we improve efficacies, general self-efficacies of patients, that they feel more that they're in control, that they make the right decisions, that they're able to do things? That's self-efficacy. How do we improve the self-efficacy, and does it make a difference? Next slide, please. And as I said, this is it's just appeared ahead of print that this interdisciplinary palliative rehab bolsters general self-efficacy to attenuate symptoms of depression in patients living with advanced cancer. And this was our study done by Andrea and Sophie LaBelle, which has just appeared. Showing, you can, next slide, please. So the results showing that there were 80 patients, C-reactive protein, because we're still looking for a biological to measure what's going on and if that can help us with their patients, but not having an effect. Exercise significantly increased, self-efficacy significantly increased, and depression scores significantly decreased. And when you did the statistics of it, there was the depression scores, that 15% of variance of change in the depression score showed that this model could explain it. And self-efficacy accounted for 11% change in this depression scores. So we concluded that self-efficacy framework may be a helpful ingredient in interdisciplinary intervention to decrease depressive symptomatology. Next slide, I think that's the last one. So as we move forward and we look forward to the future, we said from the beginning, you're having cancer and being told that you go home and there's nothing more we can do. There is something we can do. There is a bit of light at the end of the tunnel. We're all putting in effort. We're trying to heal. We're conscientious healthcare providers. We may not be treating with anti-cancer treatment, but we're treating patients with cancer. And for the first time, and I've not seen any of this other literature anywhere, we can say that we can change symptomatology, physical, spiritual, psychological, and emotional symptomatology can be changed by giving correct intervention and with correct measurement. And I know that I'm speaking to a group of people that have dedicated themselves to this. And my message is, measure properly, give the intervention, and measure again to show that we're doing what we think we're doing. Thank you very much.